Hello, and welcome to Eosinophilic Esophagitis, Guidelines and Emerging Evidence for Effective Management Strategies, presented by the Global Education Group, broadcast simultaneously on Clinical Series Live and Immunology Live. My name is Dr. Igo Hirano, and I am a professor of medicine in the Division of Gastroenterology and Hepatology at Northwestern University Feinberg School of Medicine in Chicago. Today's session is interactive, allowing us to take your questions in real time throughout this presentation. We encourage you to enter questions at any time in the box below. I'd now like to introduce my co-presenters, Dr. Matthew Greenhawt, Professor of Pediatrics at the University of Colorado School of Medicine, and Bethany Dorfler, Senior Clinical Research Dietitian at Northwestern Feinberg School of Medicine. Thank you both for joining us today. Now let's get started. Here are our disclosures. I will also mention that we will be discussing off-label use of medications. Currently, there are no medications yet approved by the US FDA for the treatment of eosinophilic esophagitis or any eosinophilic GI disease. Our learning objectives are listed here, and these include to describe the clinical presentations of EoE in infants, toddlers, older children, and adults, apply the most recent AGA Joint Task Force on Allergy Immunology clinical guidelines regarding the safety, efficacy, and appropriate clinical use of proton pump inhibition, topical steroids, elimination diets for the management of EoE in children, adolescents, and adults. And finally, to discuss the mechanisms of action, efficacy, and safety of novel corticosteroid formulations and emerging Th2 targeted pharmacologic therapies that are currently in clinical development for the management of EoE. I'll be starting off with a look at EoE epidemiology, disease burden, and diagnosis. So EoE, as you all know, has been defined through a conceptual definition as a chronic immune antigen-mediated esophageal disease that's characterized clinically by symptoms related to esophageal dysfunction and histologically by eosinophil predominant inflammation. Looking at the epidemiology, the prevalence of EoE has most recently been estimated to be about 8 cases per 10,000 in the United States. It occurs most often in patients between the ages of 25 to 50 and is at least 3 times more common in men than in women. It's been described across racial and ethnic groups, but is more common in whites. It's found in up to 23% of patients undergoing upper endoscopy for the indication of dysphagia, and in fact has become one of the most common, if not the most common, cause of food impaction. Looking more specifically at the epidemiology of EoE in the United States, this is from the figures from a study done by Dr. Evan Dellin, looking at the prevalence of EoE in the US population. Here, men have been shown in dark blue and women in white. And the prevalence has been broken down into different 5-year age brackets, going from children under age of 5, then breaking it all the way up to age 65 years of age. Of course, there are EoE patients who are older than 65. They were just not captured in this database because they were not captured in this insurance database. And you can see here a number of the major demographic features of EoE that you all see in your clinical practices. Again, the male predominance, the median age being about 35 years of age. And the other fact I like to point out, sometimes to my pediatric colleagues, although many people consider EoE to be a pediatric diagnosis, you'll notice that the majority of patients afflicted with EoE in the United States are adults and not children. Now, commonly asked question, and in fact, the question that came up already on the Q&A from the audience is what factors contribute to the emergence of EoE? Why is the prevalence of EoE rising so dramatically? And the simple answer to that question is we do not know, but this figure actually breaks down some of the major pathogenetic factors that have been identified that contribute to the emergence of EoE over the past 30 years. If we follow this pinwheel and we start the 12 o'clock position, there's the cellular elements that focus not just on the eosinophil, but also chronic inflammatory cells, mast cells, and the esophageal epithelium of the esophagus, the squamous epithelium that can demonstrate impaired barrier function. Moving to the 2 o'clock position, we have heritability factors, the observations that most patients that have been reported are Caucasian, and the higher risk of EoE amongst family members of afflicted patients. Going down to the 4 o'clock position, we have genetic variants, and a number of genes have been identified through GWAS studies in patients that have eosinophilic esophagitis. However, I should note that twin studies have identified that the majority of risk for EoE is not genetically determined, but determined by the environment. At the 6 o'clock position, we have the gender. It's quite an interesting observation that almost every study from around the globe has identified the male predominance. That's true in Switzerland, Australia, Asia, or the United States, Canada, South America. And the reasons for that male gender predisposition is really unclear. At the 7 o'clock position, we have environmental factors. Again, this is the dominant factors that are driving the rise in eosinophilic esophagitis. And some of the environmental factors that have been linked or associated with EoE are listed here, including early childhood exposures, cesarean section, early childhood antibiotic exposure, formula feeding in infancy, cold climates, and Helicobacter pylori exposure. At the 10 o'clock position, we have atopic predisposition. There's the seasonal variation that's been described for symptom exacerbations that may be predominantly in the spring and the fall, less so in the winter. Speaking to potential environmental contributions and aeroallergen contributions to the pathogenesis of EoE, at least in a subset of patients. The fact that oral immunotherapy may induce eosinophilic esophagitis in some patients. There's a high rate of concomitant atopic disease in the vast majority, somewhat 80+% of patients with EoE have extraesophageal atopic disease. And this may be IgE-mediated food allergy, it may be atopic dermatitis, it may be asthma, or it may be allergic rhinitis. Looking at the pathophysiology of eosinophilic esophagitis, it's been described as a Th2 or type 2 inflammatory condition that's marked by the infiltration of eosinophils into the esophagus, keeping in mind that the normal esophagus is completely devoid of eosinophils. So even seeing any eosinophils in the esophagus is generally a marker of pathogenesis or abnormal disease. So the primary triggers to the emergence of eosinophils in the esophagus are food allergens. However, environmental allergens may play a role, again, in the minority of patients. These penetrate through the epithelial barrier, likely due to the dysregulation of epithelial barrier function. This leads to a downstream cascade of type 2 inflammation that's characterized by key cytokine mediators, including IL-5, IL-4, and IL-13 that Matt will be describing when we talk about advanced therapeutics for eosinophilic esophagitis. The net result of this type 2 inflammation are consequences on the esophageal function that include remodeling function, namely esophageal subepithelial fibrosis, leading to stricture formation, loss of barrier function, which perpetuates the inflammation, and ongoing eosinophilic inflammation. Now, the consensus diagnostic criteria for eosinophilic esophagitis were revised in 2018. Prior to 2018, as you all recall, it was required that before you made a diagnosis of EoE, your patient had to fail a 2-month trial of high-dose PPI therapy. However, this PPI requirement was removed in 2018. Now, if you have a patient that has symptoms of EoE, namely dysphagia and food impaction in our adult patients, things that might make you more suspicious about the diagnosis of EoE would be concomitant allergic disease, again, the allergic rhinitis, atopic dermatitis, or asthma. You then proceed to performing an upper endoscopy by the gastroenterologist. And the presence of endoscopic features of EoE, the rings, edema, furrows, and exudate, should increase the suspicion of EoE because over 90% of patients with EoE have endoscopic features of the disease. Biopsies are required to make a diagnosis, and what we're looking for here is the requisite greater than or equal to 15 eosinophils per high power field to establish a diagnosis. Once you've done that, you have the necessary symptoms, you have the necessary histopathology. It's important to take one step back and say, is there any potential secondary cause of esophageal eosinophilia in your patient? You can do that by looking at the patient's past medical history, a brief consideration of reflux disease contributing to esophageal eosinophilia. And once you do that, you do not need a PPI trial. You can then go on to a diagnosis of eosinophilic esophagitis. We're going to come to our first audience polling question. And again, we're going to ask you all to participate in this. The question is, how would you rate your confidence in your ability to explain to your patients and caregivers their symptoms of EoE across age ranges? Now, a trick to this question is across age ranges. It's not just talking to your adult patients about their symptoms, but how comfortable are you at explaining symptoms across the different ages from pediatrics to adults? Are you A, not very confident, B, slightly confident, C, very confident, D, extremely confident, or E, this question is not really applicable to me? So while we're giving our audience just a moment to think about their answers here, Matt, what's been your experience as a pediatrician? Do you think the pediatric patients are comfortable in explaining symptoms in adult patients that might occur?
Everything's a little bit tricky. You know, when I was formerly at University of Michigan, I ran both the EoE program on the peds and the adult side. You know, I think in general, the referring patterns getting to see us in allergy were not always specific. Like, I think there's eosinophilic esophagitis, but they knew something was wrong and they had an idea that we might be able to help them out. You see some variability. There's some very good referring providers who identify this readily, and there's some, you know, even amongst allergists that miss this all the time. So it's hard to pin that down.
Great, thank you, Matt. You know, from the adult side, I would say that many adults are not aware that the pediatric symptoms are quite different than the adult symptoms, and we'll come back to this in just a minute. It looks like from this audience poll, the majority answered B, actually, that they're slightly confident. So we can go through this as we talk about symptom presentations. So we actually posed a similar question to a patient forum that was held, not a CME, but a patient conference that was held by Platform Q addressing EoE for patients. And a question was posed to the patients and caregivers regarding their knowledge of EoE, and could they identify symptoms that were common to children, adolescents, and adults with EoE. Majority of the audience here, the patients got the answer correctly, that it's, dysphagia is a common symptom across the age spectrum. But of note, 36% were unclear about EoE symptoms across the different age brackets. So clearly there's uncertainty both from our practitioners and from patients. So we're going to now hear from a patient regarding their child's experience with their EoE symptoms. So we're going to go to a video clip from a patient.
He actually had a lot of cramping and diarrhea, which was why they were assuming celiac. But he did have a number of episodes where I had to give him the Heimlich, and I thought it was because he was stuffing his cheeks too full of food as a toddler. And I had no idea that it was that food was getting stuck.
So I think what's quite striking from that patient's description is that their child presented not just with the dysphagia, but actually with abdominal pain and even diarrhea. So the symptoms in children, particularly younger children, infants, toddlers, and very younger children, can be quite different than what we're seeing in the adult world. So this gets to the common symptom presentations, children and adults. On the left-hand side, you're seeing the common EoE symptoms in children. Again, the children can present with dysphagia. They can present with heartburn, but more commonly, the younger children are presented with nausea and vomiting, abdominal pain, feeding difficulty, and failure to thrive. Once you get on to adolescents and adults, the symptoms become much more stereotypically dysphagia, food impaction predominantly. Those are the top two symptoms. And then less commonly, adults can present with heartburn and chest pain. Endoscopically, the endoscopic manifestations of EoE are well known to gastroenterologists because this is something that we're seeing in our practices at least on a weekly basis, sometimes even more frequently. And unfortunately, we're seeing this in the emergency room more and more as patients come in with food impactions. The endoscopic manifestations have been put into an endoscopic reference score, the EoE EREFS, which also conveniently stands as an acronym for the 5 major endoscopic features of EoE. The first E for edema or loss of vascular markings, the R for rings, the next E for exudate, the white plaques of the esophagus, the F for furrows, and the final S for stricture formation of the esophagus. Again, the vast majority of patients, both adults and pediatric patients with EoE, have endoscopic findings that will clue you into the possibility of eosinophilic esophagitis. Now, the importance of this endoscopic assessment is that endoscopic identified features, again, present in most children and adults. EREFS provides an assessment of disease activity and not just the inflammatory activity. I think biopsies are our gold standard biomarker for inflammation, but the endoscopic activity also tells us about the fibrostenotic activity. That's in the form of the esophageal rings and stricture formation. Fibrostenotic findings are what we use to make decisions about performing esophageal dilation. EREFS does show correlation with symptoms and histologic outcomes, and endoscopic activity provides a validated and objective assessment of therapeutic response that's been demonstrated in randomized placebo-controlled trials, several of which Matt will be showing us later on. One other aspect of EoE assessment and activity I just want to mention, because you're going to be seeing more and more of this as you look across clinical studies in eosinophilic esophagitis, is that EoE activity histologically is more than simply counting eosinophils per high power field. These additional histologic features are very important and have been put into a histologic scoring tool called the EoE HSS. The EoE histologic scoring tool. This has been developed by Dr. Margaret Collins at Cincinnati Children's Hospital and includes not just eosinophil density, but other markers of tissue injury that include basal zone hyperplasia, sepepithelial fibrosis, and dilation of intercellular spaces, the barrier dysfunction that we're seeing, important in the pathophysiology and pathogenesis of eosinophilic esophagitis. By looking at this more comprehensive histologic scoring tool, I think we can get a better assessment of our patients' EoE activity. We're going to come now to another audience polling question. So this is looking to your own clinical experience. So in your experience, how long has it taken your patients with eosinophilic esophagitis to get to their diagnosis? In other words, from symptom onset to the time they come to a gastroenterologist, get a biopsy, and make a confirmed diagnosis, how long has it taken them? How long has their patient journey been? Has it been A, 1 to 2 years, B, 3 to 5 years, C, 6 to 10 years, D, greater than 10 years, E, not sure, or F, I don't treat patients with EoE. And while you're thinking about your answer, we're going to go to our patient video. Our patient Chuck is going to describe his own experience with eosinophilic esophagitis and coming to our diagnosis.
It started to progress to the point where I knew something was definitely going on. So I started ratcheting up some of my my questions to my family doctor. Their course action was to send me to an allergist. They were the ones that actually were pushed me towards the EoE diagnosis. I would say it took about 5 years from the onset of the symptoms to getting an EoE diagnosis from the beginning of having these food impactions to actually seeing a specialist.
Okay, so we heard from our patient, and he actually gave what is considered in the literature to be the correct answer. The majority here answered F, interestingly, that they don't treat patients with EoE. But the usual answer in the literature right now is about 5 years. And I think what's somewhat humbling about that number of 5 years for diagnostic delay is that number hasn't changed that much in the past 20 years. So even though we're all thinking about EoE, we know about EoE, we've read about EoE, we're aware of it, we're still, there's still a delay. And that delay has many reasons, which we can get into perhaps in the question and answer period. So now let's look at the natural history of eosinophilic esophagitis. What makes EoE so important to treat is that there is a natural progression of disease to worsening disease with longer duration of untreated disease or unrecognized disease. This is data. I don't expect you to see all the quantification on the 4 different slides figures here, but these are 4 different studies, 2 from Europe and 2 from the United States. And quite interestingly, all 4 studies had the same conclusion, that longer duration of untreated or unrecognized disease led to a higher risk of stricture formation, such that in the studies with longer duration of more than 10 years, the majority of EoE patients had strictures of the esophagus. And these strictures were actually defined in one of the studies by inability to pass an upper endoscope. That's a pretty hard endpoint. So you can't pass a 10 millimeter scope through the esophagus. I think we'd all agree that constitutes a significant esophageal stricture. So longer duration of disease, higher risk of stricture formation. These natural history studies have informed this type of model for the natural history of eosinophilic esophagitis. This cartoon depicts what happens over time. On the far left-hand side, we're seeing a normal esophagus, which we can interrogate endoscopically or histologically with a biopsy. With early forms of eosinophilic esophagitis, there's mucosal inflammation. We can detect that endoscopically by the presence of edema, exudates, and furrows, and histologically by eosinophils. With longer duration of disease, there's progressive fibrosis of the lamina propria, the subepithelial space, which leads over time to stricture formation in the narrow caliber esophagus. This type of simplistic model helps us to understand the phenotypic differences between children and adults with eosinophilic esophagitis, where children are presenting on the left-hand side of the slide with the inflammatory phenotype. The adults are presenting on the right-hand side of the slide with more of the fibrostenotic complications, leading to strictures, food impaction, and progressive dysphagia. I want to come now to the importance of interdisciplinary team approaches to the management of eosinophilic esophagitis. Of course, gastroenterologists are necessary to make a diagnosis of eosinophilic esophagitis. They're needed to perform the endoscopy, to deal with the food impactions, and to get a biopsy to establish a diagnosis of eosinophilic esophagitis. But a number of other medical specialists are involved intrinsic to the care of patients with eosinophilic esophagitis. This includes our allergy colleagues like Dr. Greenhawt, who's joining us today. Our pathologists were essential to looking at the histopathology and describing not just the eosinophil density, but the ancillary histologic features that were shown in the earlier slide. Dietitians like Bethany Dorfler, who's joined us today. Primary care physicians who are identifying symptom presentations in their patients, and other healthcare professionals that include ER doctors that might be seeing these patients in the ER, ENT physicians who might be seeing patients with throat symptoms or dysphagia, and pulmonary doctors who might be seeing patients with atopic disease. We're going to now switch to the management or treatment of eosinophilic esophagitis and look at the recent AGA Joint Task Force on Allergy Immunology Guidelines and how these guidelines can be applied to your clinical practice. So we have another audience polling question. Which of the following treatment approaches do you find most useful for your patients with eosinophilic esophagitis? And again, for this question, I'll say there's no right answer. It's really looking to your own practice patterns. Are you mostly using dietary management, A? B, acid suppression with proton pump inhibition? C, swallow topical corticosteroids? D, esophageal dilation? E, medications in a clinical trial? F, other or combination of treatments? Or G, nothing. This question is not applicable to me. So again, while you're considering your answer to this, Matt, what would you put in your practice for this question? How are you directing most of your patients?
Yeah, even though I'm a food allergist in my other life, I'm a huge proponent of the topical steroids. I think they have the greatest value, and as we'll get into in my section. I'll give you the reason that I stand firmly behind sort of the evidence that was noted in the meta-analysis forming the guidelines.
And Bethany, I'm kind of leading the witness here, and you're going to give us a biased answer. But what do you think about your think is the most useful for patients with eosinophilic esophagitis?
Well, I would also say it differs by population group, because I'm very sensitive to putting kids on restricted diets, whereas adults, really enjoy the opportunity to be on a special diet as a chance to improve their diet quality. So I think we really have to consider kids' growth needs, family dynamics, psychosocial stressors of diet therapy. So I'm a huge fan of diet, but will be the first to call out when I think diet therapy is not necessarily a great fit for a kid or for an adult.
Great. And we'll probably come back to this topic a bit more in the shared decision-making, but I think this is one of the big roles of shared decision-making to help our patients go through this list of different options and how do they choose between the different treatment options. It's quite interesting that our audience actually majority picked B, which is proton pump inhibition. Actually, that's a great segue. That's what I'm going to start off by talking about therapy with PPI therapy. Before we do that, looking at the algorithm for the management of eosinophilic esophagitis, we talked initially about making a diagnosis, establishing a diagnosis, looking at the secondary causes. And once you've established a diagnosis of EoE, we do have the different treatment options available to us. And again, there's no one right answer. It's really shared decision-making. We have our medical therapeutic options, including PPIs and swallowed topical corticosteroids on the one hand side. And on the other side, we have dietary therapy that Dr. Greenhawt and Bethany will be talking about in a minute. Patients can cross over. So we have patients who start off with medical therapies and maybe they don't like to use it long-term, or maybe the medical therapeutics don't work and they switch over and cross over to dietary therapy and vice versa. Once you've had your patient respond to first-line induction therapy with medications or diet therapy, it's important to recognize that strictures may persist. Strictures don't always melt away with your induction anti-inflammatory therapy. So patients may require esophageal dilation if they have persistent dysphagia and have a stricture that has not resolved with initial induction therapy. So that's where dilation has a big role for treating strictures of the esophagus. And then once you've gotten your patient into clinical remission, symptoms are better, histology is normalized, and their endoscopy strictures have improved, we then have to consider the very, very important role for maintenance therapy. If you don't use maintenance therapy, the patients will have disease relapse. So now going to proton pump inhibition. Again, this was interesting that it was the most popular answer amongst our audience, that most of them think that the therapy they're using most commonly is PPI therapy. So when looking at the recent American Gastroenterological Association Joint Task Force and Allergy Immunology guideline recommendation, PPIs were indeed recommended. It was stated that in patients with esophageal eosinophilia, now called EoE, that these patients, the AGA-JTF suggested PPI therapy. It was given a conditional recommendation based on what was considered to be very low quality evidence. And one of the big reasons this was given very low quality evidence, although there are lots of studies showing that PPIs are highly effective, is that when you look at the data from these studies, you're seeing a lot of heterogeneity. This forest plot shows data that's all over the map, going from histologic response rates as low as 20% to as high as 80%. So when you see that type of response traversing such a wide spectrum from 20 to 80%, it makes you scratch your head and say, well, we really don't understand why patients are responding and really what a precise estimate should be for therapeutic response. We know they help, but we really don't know how effective they truly are. The other caveat I'll note about PPI therapy for EoE is that none of these trials have been placebo-controlled. They're all mostly retrospective studies, very few prospective studies, and none have randomized the patients to placebo versus PPI therapy. So a couple of take-home points for using PPI therapy for your patients with EoE. Again, PPIs are no longer required for the diagnosis. They're now considered a primary treatment option for EoE. Histologic benefits have been demonstrated both in children and adults with variable effect sizes. I usually quote my patients that about 30 to 40% of them will show a histologic response or normalization with PPI monotherapy. The slide says 30 to 50%. In my clinical experience, it's been closer to 30 to 40%. The mechanisms for benefits, why do these PPIs work? It may have to do with actual improvement in the epithelial barrier, which is one of the early steps in the pathogenesis of eosinophilic esophagitis. That's how we think the swallowed allergens, whether it's food or environmental allergens, are getting into the esophagus and activating the immune system. The other mechanism that's been proposed is that PPIs may have an acid-independent anti-inflammatory effect. PPIs, as would be surmised from the audience polling question here, are a very popular first-line therapeutic option. And that's because of their effectiveness, widespread availability, ease of administration, and safety. Most studies that have used PPIs have used them at either a double dose once a day or single dose twice daily. In my clinical practice, I'm mostly using omeprazole 40 milligrams once a day. Higher dosing regimens may modestly increase effectiveness, but I find that compliance with double daily dosing can reduce the overall compliance to medications. Finally, loss of therapeutic benefit with prolonged use has been reported in a handful of case reports, but I believe to be relatively uncommon. With that, I'm going to now transition to other therapeutics beyond PPI therapy and hand it over to Dr. Greenhawt for discussion.
Thank you. So looking at this slide, so this is a similar analysis as was seen for the proton pump inhibitors. This is a meta-analysis. It's looking at a number of different trials, and it's displayed as this forest plot. This is looking at what we call topical glucocorticoids or swallowed steroids. It's been referred to as a number of things, but the main difference in this is that we're taking asthma preparation, so either meter dose inhalers, which are now HFA, or liquid respules, and we're passing them right over the esophageal surface to act as a topical, where, you know, if this were eczema or something like that, we'd be applying a cream. We can't quite do that. And we don't want to go and take sort of oral steroids such as, you know, prednisone tablets or even an injection of a steroid. So these are topical agents being passed over the esophageal surfaces. So in this analysis, actually all of these were randomized controlled trials against placebo, which is very different than with the proton pump inhibitors. So much like in figure skating or in any sort of technical thing, this starts from a higher degree of difficulty, and it allows this to capture both a strong recommendation based on the degree of effect that was seen and a very an elegant quality of evidence, a moderate quality of evidence, meaning that we're pretty certain about this. The studies were all of good quality with very little variation between them. So what you can see here is that the relative risk for failing to achieve remission was on the low side. Over 60% were achieving remission with this. What makes this even better is that these were what we call PPI refractory patients. So these are all slightly older studies. You can look at the years. Some of these were done very early on. But this was before the guidelines were changed to suggest that you don't need to have a 2-month period with PPI. So all of these patients failed PPI therapy, so they're a different level of patient. Again, because of the use of a randomized controlled trial and a placebo, there is direct comparison. So we can say, yes, compared to doing nothing, this clearly has an effect, which is maybe self-obvious, but in the world of doing evidence synthesis, that's actually a really big deal. And you'll see this sets this analysis within these guidelines up versus some of the other stuff where there aren't direct comparators, which makes you rank it down a little bit. Now, all these studies were short-term. So these are 3-month, about 12 weeks of therapy. The endpoint also was a little bit different. Usually we consider 60 eosinophils or less as the histological endpoint. These were geared towards 15 or less. But still, it's showing an effect. Again, you can see a very, very strong thing. It's nowhere near 1. Most of these estimates are right within line of each other, very little variation. So that's what gives it the higher certainty of evidence. There's no increased evidence of adverse events that you might consider with steroids, such as things like thrush or adrenal suppression, growth suppression. This is what we consider a fairly safe therapy for all ages. This had the highest certainty of evidence and the best confidence in that evidence. So this is a strong recommendation, which in grade is rare. It really means that this should be done and that shared decision-making is really unlikely to help influence the decision because the evidence is so clear. There was no difference in the formulation noted. So in that estimate, both swallowed liquid preparations that were slurried with something to thicken it, as well as a gulp inhaler were pulled together. Sensitivity analysis showed there's really no difference in those estimates, so you could pull them together. Again, these were all PPI refractory patients who had GERD excluded. While this has the highest strength and certainty of evidence, that still doesn't mean that this is right for everybody. There are people who do exhibit very, very strong preferences against not doing a steroid for a number of reasons, and that's fine. But when you're ranking everything comparatively, this actually had the most elegant estimate based on the way that the analysis was done. Now, all of these are still technically off-label, at least in the United States. In Europe, there is a swallowed budesonide formulation. There are things that are under evaluation in the US, but these are taking asthma medications and using them off-label. Occasionally, you will get a pharmacist call you and say, I'm not sure you can use it for this, and you have to explain. Sometimes insurances, at least in the past, have denied this, but they've gotten much better over the past 15 years in doing that. If you're using the budesonide liquid preparation, multiple agents can be done to thicken it. You're just trying to thicken it up so that it drags a little bit slower over that surface. What about foods as a trigger? Part of the definition that this is a allergen-triggered disease. And yes, there certainly is robust evidence that dietary triggers do play a role here. Some of the original evidence for that was that children on an elemental diet showed near complete resolution of both symptoms and histology. And as soon as you put those foods back in the diet, they completely reversed. We now have 3 different styles of diets that can be applied that all have success. There is this concept of what's called entropy, which means localized IgE production along the esophagus. IgE is the allergic molecule, and that's really what's defining it as a food allergy. When we do skin testing or look for serologic evidence of allergy, we're looking at what's called atopy, which is more a global production of IgE. Entropy is really just sort of what's along the local area. And biopsies have shown that you can see IgE specific to foods there. Now, milk, eggs, soy, and wheat tend to be the most common triggers. What's interesting is that not all elimination diet success can be explained by allergy testing, which means that I can just randomly remove these foods from your diet, and there's a good chance that you're going to respond. But if I were to do detailed testing in a number of different ways, I might not be able to show mechanistically that you are allergic in the sense that I would call it as seeing you for IgE-mediated food allergy. And I would caution that use of the word allergen or allergy in EoE is highly different. It's almost completely unrelated to what we see in IgE-mediated food allergy. This does not cause anaphylaxis. Eating these foods is not going to result in needing to use epinephrine or anything like that. It's unclear if, every single time you eat these foods, you accumulate cellular damage. That remains to be seen. But generally, this is a very different word. I would almost say trigger as opposed to allergen. But we know that removing these triggers will normalize the biopsy and reduce your symptom loads. What's unfortunate is that the dietary approaches really have not been well compared to one another or compared to steroids. So it's really hard to say what is the best choice. Identifying the triggers, for years, we were actually using standard allergy testing and what we've used for contact dermatology testing with patch testing using fresh foods on the back. This showed some evidence, but it's fallen out of favor, and it doesn't seem to get us any further than just sort of empirically eliminating foods. And this empirical elimination diet has really shown great success. Whether it means that this can be done non-specifically or we're testing at the wrong site or we're using the wrong test, it remains to be seen. When we looked in the guidelines, I say we because I was one of the authors, when the AGA and the Joint Task Force looked at this, the level of evidence and certainty for test-directed dietary elimination really was the weakest. And again, for some, you may have success in removing some of these foods, but a true allergenic trigger defined, by a mechanism is really never identified. So there's a lot left to be learned about how we do diets and why we respond. but they do work. So here you can see 3 different types of diets: the elemental diet, which is an amino acid-based formula; the empiric 6-food elimination diet, which removes milk, egg, wheat, soy, nuts. If you consider nuts as a food group, it's really not one food group, as well as seafood, which also is not one food, but you get the gist. Sort of these 6 large groups of foods removed also showed success, as did testing with scratch and patch testing. But when we look at this comparatively, all of these are conditional recommendations, meaning that this is preference sensitive and that there's reasons that you may or may not want to choose this. The elemental diet did have a much more higher quality of evidence. This had a moderate quality of evidence recommendation, whereas the empiric diet had a low quality of evidence, and the test-basing diet had a very low quality of evidence. And how did those conclusions get reached? Well, if you squint real small here, you can see, none of these crossed 1, meaning that there was clear benefit, but the uncertainty and the spread of this were very different. Here with the elemental diet, the effect was drastic. Almost everybody that went on an elemental diet that was analyzed in this series responded. Now, the problem is that this wasn't compared to placebo or anything like that. This was a single-arm observational study. But in the style of analysis as it was done, we were able to use a placebo arm from the steroid trial, which is basically somebody who got nothing, and look to see comparatively, if compared to somebody who did nothing versus an arm that got this, how would that effect size look? And you can see this is robust. I mean, very few people failed to respond. Now, there's a little bit of spread here, which kind of break that down from high to moderate certainty of evidence. And you can see with these other styles of diet, it starts to drift back closer to 1, and there's a lot more sort of spread along these lines. So this is by far the best effect for any of the diets, but they all work. But with the allergy testing diet here, you can see this really had the lowest, very low certainty of evidence, which is basically saying that this needs a lot more work. So I'm going to flip this over to Bethany now, who's going to go into a little bit more detail about how you can execute dietary management in your therapy, and what's the role of the registered dietitian, who I would say is absolutely an essential team member in this. And it's going to be very, very hard to manage diet therapy without a dietitian in your corner.
Wonderful. Thank you for that. And thank you for giving nutrition part of the platform here today. We really want to make this practical. So feel free to, bring up any nutrition questions that you have, whether they're really about growth and kind of nutritional wellness, or about the practical implementation of the diet. So to build off of what Matthew was saying here, if we take a couple of studies and kind of throw them side by side in both kids and adults, and we look at some of these efficacy rates, as he mentioned, elimination diets are effective. Elemental is the winner. We do quite a bit of work with elemental formulas here at Northwestern, and we really try to use those as a last resort because they're very labor intensive and they can really impact quality of life. As Dr. Greenhot mentioned, the 6-food elimination diet, empiric elimination, is one of the most effective in both kids and in adults. And we've been able to see that more than 60% of our patients here at Northwestern, and certainly this has been replicated in other centers as well, are able to achieve histologic and symptom improvement in EoE on the 6-food elimination diet. But as we study this more, it's really important for us to consider, how can we simplify the diet? Because food's really important. It's why there's birthday cake. So we really want to make sure that we're optimizing and balancing quality of life. If I could let you into kind of my filter, if you will, when I'm meeting with a client, and I know I can speak for my other dietitian colleagues as well, when we are choosing what is the right diet for people, and of course I'm doing this actively with my colleagues, I'm trying to consider not only what their interest is in cooking, if they have skills, if someone is a college student and only has access to a microwave, I might think of a different level of diet restriction for them than someone who really likes to cook and has a full kitchen. Our pediatric colleagues really look closely at feeding dysfunction and growth. And one thing that's important to consider, especially if you work with kids and teens, is are they growing normally? Many of our adults will say, this is a great opportunity for me to kind of improve my diet quality. But in kids, we have to have the dual role of looking at growth and hitting those important developmental milestones. These are kind of the big 8 if we're looking at a 6-food elimination diet that we are trying to eliminate at once. And what I'd like to show you in our next slide, this was a question that came up in the chat. Once you've completed the 6-food elimination diet, and assuming, of course, that your patient has a good response, what are the next steps? Well, we have a protocol that we follow, and every center does this a little bit differently. And of course, this is altered by the level of food restriction that you might consider. But if someone is clear after their 6-food elimination diet, we start the process of reintroduction. And we sort of run the odds a little bit in an effort to reduce the number of endoscopies. We cluster some of the lower triggering foods, such as seafood and peanuts and tree nuts, into the same kind of 4 to 6 week period and repeat the endoscopy. If the histologic and endoscopic appearance of the esophagus continues to look good, then we have passed those groups, and we kind of move on to adding in soy and eggs and so forth. If someone is active, if they've recurred or been triggered, we take a step back and we wash out. We remove that food for approximately 4 weeks before we continue with reintroducing the next food. So what you can appreciate from the column on the left is the number of weeks involved in being on a lengthy elimination diet and reintroduction phase. So when you get into shared decision making, it's important to let people know and to anticipate this could easily be 4 to 6 months before we get you to a point where we can identify your 1 to 2 triggers. And this idea of 1 to 2 triggers is important because in open label studies from our center as well as other centers, we've seen that most people with EoE have 1 to 2 dietary triggers. And so researchers in Spain have suggested a kind of step up approach that you would start with least restriction, single food or 2 food like milk and wheat, in an effort to capture those biggest common allergens. If the endoscopy shows active disease, then you can have a discussion with your patients about stepping up to more food restriction or potentially switching to other food modality or other treatment modalities. And it's important here to consider that this helps reduce endoscopies. And this was something that during COVID, we were trying to be very respectful of for our patients who wanted limited hospital time. In addition to outcomes related to diet, again, we have to think about ensuring adequate nutrition and growth. So we're looking at making sure our patients have enough textures, calories, protein, and then of course, what are those healthy substitutes? I think we've all seen kids, teens, and young adults who have some element of feeding dysfunction where they are eating soft foods or a predominantly liquid diet or dairy-free Pop-Tarts, for example. And so the idea of restricting foods at that point may not be as important as building back foods. One quick thing I would mention is that most dietitians spend a good amount of time with their patients, not just talking about foods they can't eat, but specifically discussing which foods they can and providing people with adequate and intensive resources for how to cook, how to shop, how to snack really improves the performance of the diet and also the food-related quality of life. When diet is ineffective, as a team, one of the things that we consider is, are there other things that we should factor in? For example, if someone eliminated 1 or 2 foods, do we need to consider eliminating more foods? And that, of course, has to be done with the patient's best interest, that shared decision-making piece. I'm also very sensitive to consider if I've introduced a new trigger. If someone doesn't typically eat a lot of nuts or, chicken or fish, and they're on an elimination diet and they suddenly rely on those core foods, that's something that we're considering. And then, of course, when is it the right call to transition to other forms of medical therapy? We do spend some time talking about managing inadvertent contamination or inadvertent consumption, I guess I would say. We know that in EoE, we don't have to be as strict with cross-contamination like we do in IgE allergies, but we talk about reasonable avoidance. For example, making sure that you have your own condiments, you don't need new pots and pans, but cleaning them well, utilizing your dishwasher, some simple things. And I often ask people, who shares your kitchen with you? Who helps cook for you? What types of restaurants are you eating in, to really get a sense of what inadvertent consumption could be part of their diet. To summarize our discussion about nutrition, I wanted to highlight 2 kind of sample menus just to give you an idea. I always ask people to kind of share with me what they're eating, and then kind of midpoint, I try to look at what people are eating on the elimination diet. And I'm looking to make sure that there isn't accidental consumption, but also, again, looking at diet quality. You can appreciate in this sample menu of an adult client, if they were on the 6-food elimination diet, in the typical diet to the left, you can see all of the underlying foods that would have to go if they were avoiding the big 8. And I altered there for you the suggestions of foods that I would replace, especially in adults and in kids too. This is an opportunity for us to layer in diet quality. Oftentimes we can layer in healthy fats, other sources of protein, more antioxidants, more whole grains, and we can really optimize diet quality. I will say in kids, the emphasis on normal growth and oral motor development is exceptionally important. For young kids, we have to get into making sure, one, that we're using some fortified reduced allergy foods to supplement their diet, but we sometimes have to get into elemental formulas, and not as a treatment modality, but rather as a safe calorie, protein, and micronutrient substitute, especially for young kids, where removing cow's milk protein could substantially cut into their normal growth, development, and calorie consumption. So with that, I'd like to switch this back over to Dr. Greenhut so that we can round out the session, and we'll look for more nutrition questions at the end of the session.
Thank you. So as was mentioned at the beginning, most patients with EoE have at least one other allergic comorbidity. I think allergic comorbidity is very common in the general population, but we're looking at individuals who have multiple allergic problems, EoE being one of them. And one of the things that we concentrate on is managing all of this in concert with one another, because what we see is that when there's one sort of poor control with one allergic disease, we often see other things get out of control. So very often my kids have, they'll have food allergy, eczema, and asthma. They start flaring with their asthma, I'm almost guaranteeing you their eczema will become out of control. So keeping these things all in control at the same time is very, very important. EoE is really now considered a late manifestation of the allergic march, meaning, again, there's multiple degrees of atopy that we see. Some of the strategies for managing the comorbid disease, and we're looking at allergen immunotherapy for inhalant exposures. But what we've seen is that, loss in EoE, loss of dietary elimination can actually influence asthma or rhinitis remarkably. So we're really trying to manage multiple things at the same time. And the role of some of these broad biologics I'm going to get into that really hit high up on the pathways where you're seeing the sort of the master controls for multiple allergic diseases be influenced are really going to give us, I think, a huge piece of leverage moving forward. And some of these emerging agents are things that you've heard of. So anti-IL-4, anti-IL-13, anti-IL-4, anti-IL-13 receptors, anti-cyclic 8, anti-TSLP, anti-TNF, anti-IL-13, a number of different, basically anti-cytokine therapies. As of now, in the AGA Joint Task Force guidelines, really, other than diet and steroids and PPI, there really wasn't a recommendation that was asking you to consider these as therapy. Anti-IgE therapy was tried. This is actually suggested against, which is unusual and great. Anti-IL-5 is now being recommended only in the context of a clinical trial. Anti-IL-13 as well. Other therapies such as montelukast, and I know there's a question about that, cromolyn, immunomodulators, anti-TNF, really, again, only in the role of a clinical trial. The reason it doesn't say no is not that we want you to use these, but if you don't say it like this, it kind of shuts down research stuff. But these are things that really aren't mainstream yet. The things that are closest are these two classes here of biologics, which we'll go over in the next couple of slides. And I apologize, we're a little short on time. I want to make this up. So there was a recent phase 2/3 trial for a drug called larentilimab, which is an anti-cyclic 8, which is a mast cell activating drug. This was a multi-center randomized controlled trial in 276 patients randomized to both a high and a low dose and then placebo. All of them had EoE. All of them had to jump through a couple of hoops in terms of screening criteria. The endpoints in this study with a proportion reaching 6 or less eosinophils on the end of study biopsy and the dysphagia symptom questionnaire score absolute change. What you can see here is that this worked robustly for decreasing the cell count, but the absolute DSQ, the symptom score, did not meet statistical significance. So while this was shown to be very safe and the trends were seen in adolescents and even the symptomatic endpoints being met in those with more severe disease, right now this is sort of going back to the drawing board in terms of how they're going to proceed here, because this was a co-dual endpoint. We needed to really hit both to sort of move up the chain. But this does show exceptional promise. Pembrolizumab is an anti-IL-5 agent that's showing some promise in case reports. There are a couple of different flavors of anti-IL-5. Some block the cytokine, some block the receptor. These are still now being under investigation, with pembrolizumab being the one that's really sort of showing the most promise in terms of symptoms and histology, and here you can see visual inspection of the histology. More to come with this. This is sort of moving its way through phase 2 and phase 3 trials at the moment. Not much new data to report. Canakinumab is also in phase 2. This is a monoclonal anti-IL-13 receptor antibody that blocks sortin receptor subunits. Here, you're looking at data from a 16-week double-blind study and then sort of the open-label continuation through 52 weeks. And what this showed was that there was histologic relief and a trend towards symptomatic reduction that wasn't statistically significant at 16 weeks. And what you saw when you rolled over the placebo group is that they immediately saw histologic response. And again, you're seeing sort of continuation of this. So this is something that will move on to the next phase. It is showing exceptional promise as another biologic to treat eosinophilic esophagitis. And finally, we'll end with dupilumab. This is phase 3 data coming in a 3-part study. 2 of the parts were looking at weekly versus every 2 week, and then part C was looking at sort of the open label rollover in adolescents with EoE meeting certain standards. Again, a co-primary endpoint of 6 eosinophils per high power field and the absolute change in the dysphagia symptom questionnaire at 24 weeks. And this worked smashingly well. This is going to be hopefully something that's going to be considered and favorably reviewed by the FDA. It's under evaluation now. But this showed in part A, in the every week, it showed that it met both histologic and symptom endpoints. And in part C, with the continuation, also continued to hit those endpoints. In part B, with the every 2-week dosing, it hit the histologic endpoints, but missed on the symptom endpoints. So all that means is that this will likely be approved if it does get approved at just weekly dosing. No deaths, really smashing success. This has a very, very strong safety signal. It's used in very young kids for other allergic diseases. And this is sort of, for an allergist, this is a jack of all trades, because this has approval for eczema, it has approval for asthma, for nasal polyposis. Hopefully it will be approved for eosinophilic esophagitis. So in terms of treatment efficiency, one injection will be able to help us leverage a number of allergic diseases all at once, which is great. In terms of looking at selecting optimal therapy, here's where I'm going to waylay this into the shared decision-making. There is no optimal therapy. The optimal therapy is what your patient wants to do when they understand what the risk, benefits, and trade-offs are. Some prefer diet, some prefer steroids, some want to order it in a certain way, some are very much clinical trial. It doesn't matter. All of these show some efficacy. And that's the great part, is that you can be flexible here and that multiple strategies will work. It'd be nice if some of these were compared head-to-head. There are things called network meta-analysis that does do this. Without showing the slide on that, that did show that topical corticosteroids had the greatest effect. But again, this allows you to be flexible with what your patient wants. And if this fails, it gives you a number of different options to keep in your armamentarium, which is exceptionally important, because these patients do often fail the first thing that you do try. In terms of tailoring therapy, again, multiple therapies will work. So this waylays into this conversation of shared decision-making, where you can sit down with a partner and you can ask them what are they looking for in terms of treatment. Some people do not want a steroid, and they'll do anything else but a steroid. They would eliminate everything but water from their diet if it meant that much to them. Or they're like, I want to continue to eat pizza. If you tell me to eliminate milk, I'm just going to continue to eat pizza because I love that, or I love cheese or whatnot. It's usually milk or wheat that are the two hardest to sort of get full buy-in with. But again, figure out what your patient is or isn't going to put up with, what they are looking for in terms of their goals, how they want to approach this. And using those identified sort of preferences, you can then tailor a therapy. Your job is, as our job in terms of treating you, is to give you options that can work. And your job as a patient is to tell us what options you think are acceptable. And we can meet in the middle on this and sort of make a treatment plan. I wish I had a little bit more time to go into this. Shared decision-making is entirely nuanced. Everybody does this, whether you realize you're doing it in the office or not. But it's an approach that can be really, really helpful in terms of, getting full buy-in from your patients. So with that, I'm going to flip this back to IQ for question and answer. I apologize, we're a little short on time, but we'll move into this next segment.
Yeah, thanks, Matt. And thank you for kind of accelerating that last part of that discussion there. But we did have a lot of questions, and interestingly, a lot of them are actually diet related. So kudos to Bethany for inspiring a lot of people to wonder about diet. But I'm going to start off with maybe a question to Bethany about your thoughts about concomitant use, combination therapy with topical steroids and dietary therapy. We see quite a number of patients who are put on this combination, perhaps because they're thought to have more severe disease. What are your thoughts about that?
Yeah, I mean, I think one of the benefits of medical therapy is that it kind of spares our patients from having a more restricted diet. So I typically will encourage people to do one or the other. And, when Dr. Hirano and I talk about this in clinic, if someone wants to pursue diet, we will come up with a clinical strategy to, kind of take them off of some of their swallowed steroids with the idea or topical steroids rather, with the idea that steroids work so well, it will kind of mask what benefit or lack thereof you're getting from diet. So I think it's important to maybe pick one therapy or the other, especially if you're identifying triggers and not both.
Great. Thank you. And I think we'll stick to the short answer. That was perfect, Bethany. So Matt, question to you about associated medical conditions with EoE. And I suspect you're looking at questions about celiac or autoimmune disease and any data on that?
Yeah, so this is an allergic disease or inflammatory disease. It's not autoimmune. But we do see some overlap, and there's about 1.5% of the genes in EoE are common in celiac, and there often is a little bit of overlap. And I've seen a number of patients with celiac disease who have been found to have incidental esophageal eosinophilia. They're not symptomatic. They were scoped for another reason, and then they were sort of sent to me to manage this. You can see overlap. I've even seen sort of where they read in kids who have something called a tracheoesophageal fistula. I've even seen esophageal eosinophilia form there, right where they sew the pieces of tissue back together. So you can see esophageal eosinophilia in a number of other conditions, including autoinflammatory or autoimmune disorders, but that doesn't make it an autoimmune disorder. So that's sort of the short answer there.
I'll quickly field. There were several questions about surgery for eosinophilic esophagitis patients, gastric sleeve, Roux-en-Y gastric bypass, and fundoplication for hernia. What do you do if you find eosinophils or eosinophilic esophagitis? And just a couple of things I'll say about that. One is these are often incidental findings. They're getting an endoscopy pre-op, and they're found to have some eosinophils on a biopsy. But I carefully look to make sure they don't have active severe disease, that is stricturing disease. If they have EoE with strictures, then I'd be concerned about doing a fundoplication or about doing a sleeve or even a Roux-en-Y gastric bypass, because their strictures may be an issue with dysphagia assessment from those surgeries, all of which can produce symptoms of dysphagia. So for mild disease or incidental findings of esophageal eosinophilia, I really don't worry about that. If you're not certain, I think barium swallow with a barium tablet would be a good idea to make sure that they're not having a stricture that you haven't identified. But the other thing I would do before proceeding with the surgery is just make sure you control their eosinophilia, whether it's with a PPI or a swallowed topical steroid or dietary therapy, make sure that you can control it pretty easily so they don't have refractory disease before you go on to surgery. Another question for Bethany here is about patients who fail 6 food elimination diets and then want to transition to medical therapy. How quickly do you reintroduce the foods? Can they just go right back to all 6 foods? Do you have to worry about that?
Yeah, I might actually have Matt chime in on this one. Typically when people are going back to medical therapy, we allow them to, just really kind of open up their diet. The people that we're a little more cautious and we really rely on our allergy colleagues are people who maybe had a food allergy as a kid that they outgrew, they've removed that food, or they've had symptoms with accidental exposure, and then we want to manage that food reintroduction carefully.
Yeah, I mean, in general, if you have a pre-existing Ig-mediated food allergy that's resulting in anaphylaxis, hives, et cetera, we leave that alone. We don't reintroduce those foods. But if you fail dietary therapy and you're going to medical therapy, I will, what's the term we're using now? Let it rip. It doesn't really matter at that point, and you can sort of you can just go. However, this is where you can do that overlap therapy sometimes, and you can kickstart. And once they clean their inflammation out, then you can see on the other side, as you slowly walk back some of those foods, you might be able to see something. But this is an art, not a science. That's what I would say with food removal and food add back. If you have access to things like transnasal endoscopy, you might be able to do this a little bit faster. At Children's Colorado, we have an aggressive program for that, where we've been able to accelerate some of our add backs, after 2 weeks or so to see if it's really making a difference. Which when you need a sedated endoscopy, it might be a little bit harder to get timed, at least in kids. We're using the OR. On the adult side, we have an endo suite. It might be a little bit easier if you're blessed with all that space. But this gives us, makes it more of an office-based procedure at this point, and it can be accelerated.
Well, thank you both so much, and I apologize to the audience that we're not able to answer. There were several other fantastic questions here. I would also like to thank Regeneron Pharmaceuticals, Sanofi Genzyme, and Takeda Pharmaceuticals USA for their support of this educational activity. A companion patient session entitled Eating Without Pain Partnership for Effective Management of Eosinophilic Esophagitis is available on demand at medlive.com. And I want to remind you to complete your post-test at the end of the session to secure your CME credits. Please visit clinicalserieslive.com and immunologylive.com to view today's session along with other sessions on demand. My name is Ika Hirano, and thank you again for joining us.